this video, let's talk about conditions that affect the vulva and the cervix. Let's first talk about vulvar squamous cell carcinoma. The two big risk factors for this are HPV and chronic tobacco use. And patients will present with a friable mass on their labia majora, and they might have intermittent bleeding. So to diagnose this, you want to do a biopsy. Next, we have vulvar lichen planus and vulvar lichen sclerosis. For both of these, to diagnose it, you want to do a biopsy, and to treat it, you do steroids for both. Now, to tell them apart, so vulvar lichen planus, this will be pruritic. It'll be so itchy, it'll be purple, it'll be serosanguinous discharge, and they'll have wickium striae. So these are the white striae around the labia, and they'll also have oral lesions sometimes. It's associated with having hepatitis C, taking thiazides or ACE inhibitors, to look for those clues. So for vulvar lichen sclerosis, this is super itchy. So patients will have erosions and fissures that'll occur from all the itching, and that can cause urethral obstruction, and they might present with symptoms like dysuria, incomplete voiding, and they also have thin, white, wrinkled skin. And also there's no vaginal involvement. The other big thing is that lichen planus sclerosis can lead to cancer, specifically squamous cell cancer. So I would remember the S for sclerosis with S for squamous cell carcinoma. So just know these differences in buzzwords to kind of tell them apart. Vulvodynia is just painful vulva. So patients will have a raw burning pain. They'll have a positive Q-tip test. They'll have pain, specifically separation of the labia. And treatment for this is CBT, pelvic floor exercises. Now, for cervical cancer, there's a lot of risk factors for this that include smoking, tobacco use, multiple sex partners, early onset of sexual activity, and having HPV 16 or 18, as well as taking OCPs. So OCPs protect against endometrial cancer and ovarian cancer, but it can actually cause cervical cancer. Patients with cervical cancer can present with postcoital or intermenstrual bleeding. They might have a painless ulcerative lesion. They'll usually have a friable exophytic cervical lesion, and the exophytic characteristic comes from the HPV. For cervical cancer screening, you start screening at age 21, despite if you've already been sexually active or not. You don't start screening before age 21. And from the ages of 21 to 29, you do cytology every 3 years. Once you reach 30, so from age 30 to 65, you do cytology and HPV co-testing every 5 years. If they don't do the HPV co-test, then you start to do the cytology every 3 years. To diagnose cervical cancer, you want to take a biopsy. Let's say someone's a pap smear and it comes back as ascus, or you have low-grade squamous intraepithelial lesion, so LSIL, then you want to get another HPV co-test. Now let's say it comes back as HSIL, so high-grade squamous intraepithelial lesion. Then you want to do a colposcopy, which is where you go in and look at the lesions, and a biopsy. You can also do a LEEP for further analysis of the tissue. If you're worried about a pregnant patient possibly having cervical cancer, it's important to continue to do further testing, but you should not do a LEEP because if you do a colonization or a LEEP, that can potentially cause a risk factor for preterm labor, and the colonization can also cause cervical stenosis. If the colposcopy and the LEEP don't say it's CIN2 or CIN3, which is the more progressed stages, then you can just do a repeat colposcopy and cytology every 6 months for about 2 years to make sure that things are not progressing. If it comes back and it is CIN3, then you're more worried, and you can do cervical colonization as diagnosis and treatment for it. If it's more invasive, then you might have to do a hysterectomy. It's important to remember the risk factors after someone gets colonization, which can be cervical stenosis, preterm birth, or premature ruptured membranes, and also can cause second trimester pregnancy loss. In pregnant patients, they still go through routine screening, and let's say you are worried about cervical cancer and you need to do further testing, you should not do a LEEP or an endocervical curettage because that can cause pregnancy loss, but you can do a colposcopy because you still want to assess to see how bad it is.